Hey guys, it's Medicosis Perfectionalis, where medicine makes perfect sense. Let's continue the great endocrinology playlist. In previous videos, we have talked about clinically oriented anatomy, embryology, histology. Now it's time for pathology, baby. So let's get started. If you remember, my hematology and pulmonology playlists were epic, and we will make endocrinology epic too. Please watch these videos in order. The hypothalamus is the CEO, pituitary is the general manager, and we have 3 employees that listen to the pituitary and 3 employees that could not care less. Let's talk about atrophy. What's atrophy? Decrease in the size and the weight of the organ. We have 2 types of atrophy. Physiological, no big deal. Pathological, big deal. Physiological, like after menopause, there is ovarian atrophy. When you grow up, your thymus atrophies. All of this is fine. Pathologically, however, can be subdivided into generalized and localized. Example, cancer. Yes, cancer can atrophy all of your body. Starvation can cause atrophy of all of your body. Cachexia, marasmus, etc. Localized. We have many types of atrophy here. Disuse atrophy. You're not moving your left arm, you can get some atrophy. Pressure atrophy. Like a stinking cancer, and this stinking cancer is obliterated the organ next to it. And this is an example of atrophy caused by pressure. Vascular atrophy. Yeah, no blood supply, no food, I will starve. Neuropathic. No nerve supply, my muscle will crumble. Hormonal atrophy. Example, after bilateral oophorectomy, which is surgical excision of both ovaries, breast atrophy can ensue. Why is this? Because what did the ovaries secrete? Estrogen, progesterone? Yeah. Without estrogen and progesterone, the breast is gonna suffer because the breast is sustained by estrogen and progesterone. However, the breast milk is made by prolactin and ejected by oxytocin. Ejected is not a good word, let down is more. You know what I mean. Let me give you an example of pressure atrophy. You see this aortic aneurysm right here? Yup, it's pressing on the vertebral body. This is called pressure atrophy. As you know, the vertebral body is vascular. When you press on it, you deprive it from its blood supply, and that's why your vertebral body will suffer pressure atrophy, and this is visible in X-ray. However, the intervertebral disc is avascular. It did not need blood vessels to begin with. So when you press on the blood vessels, nothing happens. So your vertebral body will be destroyed, the disc will be fine. This is aortic aneurysm. Cancer, same thing, pressure atrophy, metastasis, vertebral body only. But the stinking tuberculosis can eventually go to the body and the disc. And if you are immunocompromised, you will have a cold abscess with no pus. That's not fun. Abscesses are supposed to be warm and tender. Now, atrophy is when your tissue is crumbling, but how about cellular growth? Okay, we have hypertrophy, hyperplasia, metaplasia, dysplasia, and neoplasia. And we have talked about them in previous videos. Let me give you an example of hypersecrete. Let's say my gland is hypersecreting. What could this be? Well, it could be hyperplasia, it could be adenoma, which is a benign tumor, or it could be an adenocarcinoma, which is a malignant tumor. But when a gland is hyposecreting, this could be atrophy. It could be crowding out, such as cancer, or it could be something nasty, like autoimmune antibodies or autoantibodies. In one of my previous endocrinology videos, we have compared among dermoid cyst, pharyngeal cleft cyst, aka branchial cleft or lateral cervical cyst, and thyroglossal duct cyst and accessory thyroid tissue. It's very important to know the difference between all of them. Dermoid cyst, usually lateral aspect of your eyebrow. Pharyngeal cleft cyst, branchial cleft, lateral, it's lateral, along the anterior border of the sternocleidomastoid. But the thyroglossal cyst is a freaking midline structure. Accessory thyroid tissue, it's in the midline, could be anywhere from your tongue all the way to where your thyroid is supposed to be. Because wherever there is a path, there is mathematical probability. The stinking tumors, whether benign or malignant, they could be functional or non-functional. What do you mean by functional? They secrete something. What do you mean by non-functional? They are cold. They are not secreting anything. If they secrete, we call this a paraneoplastic syndrome. A neoplasia is a tumor. Para is parallel. So you have the neoplasia and something parallel to it, the secretion. An example is the pituitary adenoma. The pituitary adenoma is a tumor. That's number 1. Paraneoplastic, let's say that this adenoma is secreting tons of prolactin. This hyperprolactinemia is an example of a paraneoplastic syndrome. Non-functional tumors, as well as functional tumors, can exert what's known as a mass effect, some pressure action going. The same freaking pituitary adenoma can have some mass effect. It can press on the optic chiasm, giving you a bitemporal hemianopsia, aka tunnel vision. This stinking tumor is a mass. It can give you headache because it's in your brain, and as you know, there is something called the Monroe-Kelly hypothesis in neurology. Basically, it says that your skull is 100% packed. There is not an inch empty. So, anything that increases in size has to press on something else, increasing your intracranial pressure and causing headache. So, whether you have a tumor, an aneurysm, or good old vasodilation, all of them can give you headache because there is no space empty in your skull. Pituitary adenomas can secrete something. In many cases, some brain tumors do not secrete anything, they just have the mass effect, compression of the pituitary gland. This can lead to not hyper, but hypopituitarism. Your pituitary is not making dork. What's the difference between pituitary adenoma and a pituitary apoplexy? Pituitary adenoma is a benign tumor. This is an enlargement. It's getting bigger and it's hypersecreting. Not always, but in many cases. Pituitary apoplexy is bleeding into a pituitary adenoma. The way I remember it, remember the vessels? Yeah, sometimes they form a plexus. Oh, so this is usually a bleeding into a pituitary adenoma. Of course, if I bleed, my pituitary will be without oxygen, without nutrients, because the blood supply is gone, and now I will get hypopituitarism, which means decreased secretion of the pituitary hormones. Moreover, postpartum necrosis, aka Sheehan necrosis, can lead to hypopituitarism and failure to lactate because of low prolactin. Let's talk about prolactinoma. Believe it or not, it's a pituitary adenoma. And let me remind you, the pituitary had an anterior part and posterior part. When it comes to the anterior pituitary gland, it has chromophils and chromophobes. Chromophils are colorful, but chromophobes, they hate color. Let's talk about chromophils. I could be pink, I could be purple. Acetophils or basophils. Acetophils include the cells that make growth hormone, called somatotrophs, because this is your somatotropin, and lactotrophs, because this is your lactotropin, aka prolactin. You can also call them mammotrophs because they supply your mammary glands. So what's happening in prolactinoma? Well, in prolactinoma, the lactotrophs are getting bigger and they are hyperfunctioning. Too much prolactin is gonna go to the breast. Too much stimulation can lead to galactorrhea. Let me tell you about the relationship between dopamine and prolactin. There is a video on my YouTube channel known as Dopamine and Neural Pathway. It was magnanimous. Dopamine has different functions based on its different locations in the brain. At the nigrostriatal pathway, it's concerned with movement. Too much dopamine, you're moving like crazy. Too little dopamine, you have kind of a Parkinson-like phenomenon. How about dopamine in the mesocortical limbic system? Mood and reward. Too much dopamine, you're all over the place, so hyper, euphoric, psychotic, hallucinating. But too little dopamine, yeah, I don't care, life is meaningless, and stoicism taken too far. How about dopamine at the tuberoinfundibular region? And now this is what we're talking about. Here, dopamine is anti-prolactin. Too much dopamine, no prolactin. Too little dopamine, prolactin is crazy, uninhibited, hyperprolactinemia, which can lead to galactorrhea and suppression of the GnRH, which will lead to amenorrhea in females, impotence and gynecomastia in males. So what are the symptoms of a prolactinoma, which is a pituitary adenoma? Galactorrhea and amenorrhea in females, impotence or gynecomastia in males. And here's everything you need to about dopamine in one chart. Prolactinoma, a pituitary adenoma. Symptoms are here. Diagnosis, MRI of the brain. Treatment, you can remove it surgically, but before you do this, try some medications. A dopamine agonist, because remember, dopamine is anti-prolactin at the tuberoinfundibular pathway. Example of dopamine agonists include bromocriptine and cabergoline. A pituitary adenoma, such as a prolactinoma, can compress on my optic chiasm, giving me a bitemporal hemianopia. How about Sheehan syndrome? Now this is a pituitary that's shrinking and suffering because in the good old days when I was pregnant, I had tons of blood supply to my large pituitary. After pregnancy, I lost lots of blood, and now my big pituitary is left with no blood. I can end up with hypopituitarism and failure to lactate. Where did your pituitary come from? Well, it depends. If you're talking about the anterior pituitary, it came from the ectoderm of the roof of the stomodium. The word stomata means mouth. Oh, this is basically the roof of your mouth. However, posterior pituitary came from the neuroectoderm of the floor of the diencephalon. And that's why it listens to the hypothalamus, the CEO, because hypothalamus is also part of the diencephalon. Medicine makes so much sense once you understand what the flip you're talking about. You want something more? Okay. Where did your optic nerve originate from? It originated from the diencephalon as well. And that's why a pituitary adenoma can compress your optic chiasm, giving you a bitemporal hemianopsia. Some congenital anomalies of your pituitary agenesis. No genesis formation. There is no pituitary. Or absence of the anterior lobe. Why? Failure of development of the Rathke's pouch, because the Rathke's pouch is responsible for anterior pituitary. How about the posterior pituitary? Oh, this one comes from the infundibulum. Next, you have a pharyngeal hypophysis, a pituitary in your pharynx. What the what? Yes, because it started at the roof of your mouth. It makes sense once you understand what you're talking about. So, normally, your anterior pituitary came from here, the roof of the stomodium, which is the Rathke's pouch. But the posterior pituitary came from here, from the infundibulum, which came from the diencephalon. That's why hypothalamus is here. Posterior pituitary is just a continuation of the hypothalamus. To know more about the ADH and oxytocin and why they came from the posterior pituitary and not the anterior, watch my previous videos. It was profound. What is craniopharyngeoma? A brain tumor made from the remnants of the Rathke's pouch. It's another freaking pituitary tumor, can compress your optic chiasm, giving you bitemporal hemianopsia. That's it. The tumor sits here, compresses on the nasal fibers of the retina, which corresponds to the temporal visual field. That's why you have lost both your lateral fields. Posterior pituitary is connected to the diencephalon. Optic nerves came from the diencephalon, and that's why they are close to each other. What is empty sella syndrome? What is the sella? We're talking about the sella turcica, which literally means the Turkish saddle. Who named these things? Basically, an empty sella means when you take an MRI of your brain, there is no pituitary. Like, what the what? What happens? The arachnoid, which is one of your meninges, took some CSF and came here, destroyed the freaking pituitary, and killed it. This is what happened. Now, I don't mean like annihilated the pituitary, they just flattened it. That's why you could not see the pituitary as normal and doozy like this. Let's talk about the thyroid gland. Let's start by your CEO. Who is the CEO? Hypothalamus secretes TRH. TRH goes to the general manager, the anterior pituitary. The anterior pituitary will secrete TSH. TSH is coming from the anterior, not the posterior. That's a stupid mistake. Sorry about this. TSH goes to the thyroid gland. Now, the thyroid gland is one of the 3 employees that listen to the pituitary, and it will secrete T3 and T4. Let's say my thyroid is not secreting T3 and T4. Okay, what could be the problem? The problem could be in the freaking thyroid itself. We call this primary hypothyroidism. Or the problem could be in the general manager not giving enough commands, TSH. And this is called secondary hypothyroidism. Or the problem could be in the CEO. And this is called tertiary hypothyroidism. So when I say primary hypo or hyper whatever ism, primary means in the gland of concern. Primary hypothyroid, where's the thyroid? Here. It's in the freaking thyroid. How about secondary hypothyroid? Where's the thyroid? Here. Go one step above, one step before. So the problem came from the pituitary. How about tertiary? Oh, this came from the hypothalamus. 2 steps above the gland of concern. How do I know the gland of concern? It's in the freaking name of the disease. You said hypothyroidism, it has thyroid in it. So we're talking about the thyroid. Tertiary means you jump twice. The problem is in the hypothalamus. An excellent doctor will look at the TSH. TSH is normal, therefore your thyroid gland is normal. End of story. I know it did fly over your head. Let me explain what I was saying. Example, let's say you have primary hypothyroidism, okay? Primary hypothyroid. The thyroid is not secreting, and the problem is in the thyroid itself. So T4, low. As a feedback, TSH is high, TRH is high. Secondary hypo. Now, the problem here is in the pituitary, decreasing TSH. This will lead to decreased T4, and of course, the hypothalamus will respond by increasing the TRH. Tertiary, now blame your freaking hypothalamus. Low TRH and therefore low TSH and therefore low T4. Primary hyperthyroidism is the opposite. Have you noticed? Anytime you had a thyroid problem, the TSH was abnormal. And that's why if your TSH is normal, now I know that the thyroid gland is normal. By normal, I mean it's not hypersecreting or hyposecreting. A tumor is a neoplasia, is any word that ends in oma, except Oklahoma. Is divided into benign or malignant. Malignant is divided into carcinoma or sarcoma. Carcinoma is cancer of epithelial origin. Sarcoma, cancer of connective tissue origin. Carcinomas metastasize to the lymph. Sarcomas love to metastasize to the blood. Let's talk about your thyroid gland. Do you think it's going to be a carcinoma or a sarcoma most of the time? Well, it's a thyroid gland, right? Therefore, it has what? Glandular epithelium. And that's why most of the thyroid cancer is going to be a carcinoma, and that's why it's going to metastasize to lymph. Okay, which lymph nodes will be enlarged and painless? Well, where is your thyroid gland located? It's located in my neck. Okay, where does your neck drain? Well, the head and neck, all of them drain eventually to the deep group of cervical lymph nodes. And this is what will happen if you have thyroid cancer. Cervical lymphadenopathy. Medicine makes so much sense once you understand what the flip you're talking about. It's not hard, it's just your professor is woke. Let's talk about a palpable thyroid nodule. You touched the patient's neck and you found a palpable nodule. What could it be? First of all, the nodules could be just one nodule or many nodules. They could be hot or cold. What do you mean? A hot nodule is a nodule that's secreting tons of T3, T4, which will decrease TSH and TRH as a negative feedback. But a cold nodule does not secrete anything, doesn't have any feelings. Thyroid nodules could be benign, could be malignant. Let me tell you something. If the nodule is hot and hypersecreting, it's almost never malignant. How about if it's cold? Most of the time it's benign. It could still be malignant. How do you remember this medicosis? I remember my lymph nodes. Remember, sometimes the lymph nodes are enlarged and painful. Sometimes they are enlarged and painless. Which one was cancer? Which one was infection? Well, the painful was an infection, and the painless was a cancer. Okay, so cancer was a painless lymph node. Yes, and cancer is a cold thyroid. Cancer doesn't have any feelings. Let's play this game. You found a palpable thyroid nodule. It could be hot, it could be cold. It could be benign, it could be malignant. Now, why is the cold circle bigger than the hot circle? Because statistically speaking, most of the palpable thyroid nodules are cold. And statistically speaking, most of the thyroid nodules are benign. So calm down. Okay, let's say that this thyroid nodule was hot, which means hypersecreting. It's almost always benign. The entire red circle is benign. I said almost always, not always. What if the thyroid nodule is cold and not responding? Most of the time it's benign, but it still could be malignant. It is a possibility. You can also do it the other way around. If the thyroid nodule is benign, it could be hot or cold. If the thyroid nodule is malignant, it's almost always cold. Some words of wisdom. Type 1 versus type 2. Whenever we divide something into type 1 and type 1 is usually the problem in the ligand and type 2 in the receptor. Don't believe me? Consider diabetes. Type 1, no insulin. Type 2, well, there is insulin, it's just the receptor is not listening, called receptor resistant or insensitivity. How about diabetes insipidus? Type 1, no ADH. Type 2, well, there is ADH, it's just the kidney is not listening. How about rickets? Type 1, no enzyme. I mean the 1-alpha hydroxylase. Type 2, well, like everything is fine, it's just the receptor is not listening. Another way of looking at 1 versus 2 is looking at number versus function. Platelet problem could be thrombocytopenia or thrombasthenia. Hemophilia could be due to decreased amount of the factor or decrease the function of the factor. Treatment of asthma could be targeted to decrease the amount of leukotrienes or to decrease their function by inhibiting the receptor. There are 4 main types of thyroid cancer: papillary, follicular, medullary, and anaplastic, and we'll talk about this in a separate video. Hypersensitivity reactions. We have 4 types of hypersensitivity. 1, 2, 3, and guess what? 4. Oh, by the way, if your professor taught you that there are 5 types of hypersensitivity, your professor is crazy. I know many schools have in their curricula that there are 5 types of hypersensitivity. I don't care. Give me 2 reliable textbooks that say that there are 5 types of hypersensitivity and I will apologize to you. There are no 5 types, only 4. If you believe there are 5, you might as well believe in the tooth fairy. Only 4 because there are only 4 stories. Story number 1. This is the disgusting stuff. Ew. Atopy, anaphylaxis, allergy, rash. Ew. This is what happens when the bee stings you. This is what happens when pollen and dust stimulates you. This is the land of bee stings, asthma, atopy, allergic rhinitis, atopic dermatitis or eczema, etc. The second story is antigen-antibody complex, where on the surface of the cell, that's why type 2 is cytotoxic. Cyto means cell. If the antigen-antibody meets here on the surface of the cell, this is type 2. One example is hemolytic anemia. If there is an antigen-antibody on the surface of your red blood cell, they will destroy it, causing hemolysis. Goodpasture syndrome, but instead of your red blood cell, it's in the kidney and the alveoli. How about Graves' disease? Now, Graves is weird. Why? Because most of the time, whenever an antigen-antibody binds something, they will destroy it. They will inhibit it. The only time you find antibodies stimulating the function of the target organ is with Graves' disease. If you know a second example, let me know. I don't think there is any. It's just Graves. These antibodies bind to the thyroid and actually stimulate the production of T3 and T4. And this is what some of you consider as type 5 hypersensitivity. It's not type 5, still type 2 because it's cytotoxic. It happens on the surface of the thyrocytes. But it's not type 5. It's still in the same story. Antigen antibody on the surface of a cell. How about type 3? Well, there's an antigen antibody, but not on the surface of a cell. They are floating freely in the serum. This is the story of the serum sickness or the Arthus reaction. One is diffuse and acute, the other is localized and subacute. Type 4 is the delayed story. Takes longer, 3 days, 2 to 3 days. This is the delayed. If it's going to be delayed, it's going to be your T lymphocytes. This is the story of your granulomas, the tuberculosis, histoplasmosis, blastomycosis, coccidioidomycosis, etc. This is the tuberculin test of tuberculosis. This is the poison ivy. This is the contact dermatitis, etc. Why did we classify them 1, 2, 3, and 4 based on 2 things? Number 1, the story. Each one has a unique story. Number 2, the time frame. Type 1 is immediate. It happens within minutes, but type 4 takes about 3 days. 2 and 3 are in between. Hey medicosis, what's the difference between allergy and hypersensitivity? Well, hypersensitivity is a heightened allergy. Hypersensitivity is a subset of allergy. Next, let's talk about Ducourvin. The French doctor, I think he's French, like he ought to be French. Wait a second, let me check. Oh, he's Swiss. From Switzerland. Okay, so it turns out Ducourvin is as French as Juicy Smollier. That's a terrible joke, I'm sorry. It was just a low-hanging fruit, but I apologize. I love you all. Ducourvin discovered 2 diseases in medicine. Ducourvin thyroiditis and Ducourvin tenosynovitis. I have a video about Ducourvin tenosynovitis on my channel. Now let's talk about Ducourvin thyroiditis. Let's say that you are a doctor. You touch the patient thyroid. The patient jumped off the exam table, or the patient kicked you or did something dramatic. That's how painful it is. This is your diagnosis. This patient had Ducourvin thyroiditis, also known as subacute granulomatous thyroiditis. Now let me ask you a difficult question. What if you touch the patient's thyroid and it's hard as a rock? What is this? This is Riddles fibrosing thyroiditis. Riddle because it's a rock. Let's have some fun. What is the cheapest way to diagnose Graves' disease, hypothyroidism, Cushing syndrome, or acromegaly? And the answer is an old driver's license. Compare then versus now. The patient will be changing, but the change is gradual that the patient might not notice. Another question. What if you found that a patient had a solitary pulmonary nodule? What's the cheapest way to make a diagnosis, whether it's benign or malignant? Compare this x-ray with a previous x-ray. A third question. How can you diagnose diabetes insipidus before even taking the patient's history? The patient is always carrying a huge bottle of water and they prefer ice water. Let's talk about your adrenal. Whenever you have something hypersecreting, it's usually affecting one layer. Example, adrenal hyperplasia, adenoma, or carcinoma. I can have adrenal hyperplasia in just the granulosa, or a hyperplasia in just the fasciculata, or in just the reticularis. But if it's a hyposecretion problem, it's usually destroying the entire cortex. Example, Addison disease. Do you think those autoantibodies care? No, they are nasty. They destroy everything. Tuberculosis, same thing. Do you think this granuloma cares? Nope, destroys everything. It even destroys the vertebral body and the disc. Do you think it's gonna stop at the fasciculata? Shut up. Next, Zellballen, which literally means ball of cells. These are pale, eosinophilic small nests of chromaffin cells or chief cells. You can see them in Pheochromocytoma or paraganglioma, because remember, what's a Pheochromocytoma? Tumor of the adrenal medulla. And what's the adrenal medulla? A modified ganglion. I've told you, it makes sense. Pheochromocytoma is what? Is basically your adrenal medulla secreting tons of epinephrine and norepinephrine and dopamine. And therefore, how do I know? You can find lots of epinephrine, norepinephrine, dopamine in the blood. You can find lots of HVA and VMA in the blood and the urine. Symptoms of pheochromocytoma, the 5 P's: pressure, palpitation, perspiration, pain, and pallor. Do you want the 6th P? It comes in paroxysms, which means in attacks. What are APUD cells or APUD cells? Well, amino precursor uptake and decarboxylation. Well, that was dadgum insightful. What the flip does that mean? Amino, right? You know amino acids and amines? Yeah, chemistry stuff. Yep, precursor. Oh, so before. Uptake. Okay, so we'll take them in to the gland and decarboxylate. Look at your adrenal medulla, for example. Look at this. What are these? Oh, amino acids, so amine. Okay. Precursor. Nice. Uptake, come into my gland, and decarboxylation. And that's why your cells of your adrenal medulla are APUD cells. Let's have a question. The previous questions are in previous videos in this endocrinology place. 55-year-old male comes to the emergency department with sudden, severe headache, double vision by temporal hemianopsia. He developed cardiovascular collapse and died suddenly. What's the most likely thing to be seen on brain autopsy? Another question. You took a biopsy from the kidney, and what you saw was described as thyroidization of the kidney. The kidney was trying to become a thyroid with follicles. What's the name of this disease? You'll find the answer to these questions in the next video. Some words of wisdom. Doing 90% of what's required is one of the biggest wastes, because you have nothing to show for all of your efforts. But doing 110% of what's expected is one of the smartest investments, because it can pay off with big reputation for just a little more effort. So please do not give up too early. If you like this video, you will love my antibiotics course. We talk about antibacterials, antivirals, antifungals, and antiparasitic drugs. You can download it today at medicosisperfectionalis.com. You can also get my autonomic pharmacology course, my anti-cancer pharmacology course, and many others. And you can get a 30% discount towards anything on my website. Just use discount code SAVE30. It's only available for the next 13 students. Thank you for watching. Please subscribe, hit the bell, and click on the join button. You can support me here or here. Go to my website to download my premium courses. Thank you for watching. As always, be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine makes perfect sense.